Well, thank you. It's great to be back. I was here, say, 4 years ago in 2011 for, I guess that was the first meeting, and it's great to be back. Thank you all for coming today. So it's great to be here. Now, you've heard a lot this morning about epidemiology and prevention, and you'll see that my talk is going to be more about treatment of these conditions once they've already occurred. That's largely a reflection of my research interests. But I think it'll all fit in very nicely with the rest of the talks you've heard today, and we'll hear as the meeting progresses. Okay. Here I'm listing disclosures of a few companies that have supported some of my research interests and speaking engagements. So we'll go through a few selected natural therapies that are especially popular in the United States and worldwide that people use to promote mental health. And we'll talk about some of the risks and benefits regarding these remedies. And this way, for those of you who work in clinical settings and may have patients who are interested in trying these therapies or who may already be using them, it'll give you a framework for being able to advise these patients on the pros and cons of these therapies. Complementary and alternative medicine, despite its name, is actually more popular in many ways than standard medicine. More than 70% of the world uses it in some form or another. One reason for this is for its easy access. In the United States, and elsewhere, you don't need a prescription to buy an herbal remedy over the counter, such as omega-3 or St. John's wort or some of the other things I'll talk about. Also, these herbal remedies and natural remedies are generally well tolerated. They have more mild side effect profiles compared to standard antidepressants and anxiolytics. On the other hand, the research on efficacy is fairly limited compared to some of the standard antidepressants. There are also concerns about great variability between different manufacturers, so different preparations may have different degrees of purity. There are also concerns about toxicity developing with some natural products, as well as adverse effects in general and interactions with standard drugs and with other herbs. In the US, most of these therapies are not covered by medical insurance, and so for many individuals who wish to use them, cost can be a significant factor. And finally, we don't have a lot of systematic education on the proper use of natural therapies in medicine, and likewise, consumers are bombarded with a lot of different types of information, conflicting information, and many of them don't know exactly how to make an informed decision. And as physicians, one of our responsibilities is to help these individuals understand how best to use these treatments and when not to use them. I'll start by talking a little bit about St. John's wort, which is the most popular herbal remedy worldwide. It's also one of the better studied ones. There's somewhere in the neighborhood of 40 published clinical trials on St. John's wort for depression. Including 26 placebo-controlled studies, 14 comparisons against tricyclic antidepressants, and 13 comparisons against SSRIs. And many meta-analyses have also been published at this point, as well as Cochrane reviews. Typically, St. John's wort is dosed in the range of 900 to 1800 milligrams a day, usually divided on a 3 times daily schedule. So what does the body of work show us thus far? Well, in general, most of the studies have shown that St. John's wort is more effective than placebo. It's about equivalent to low-dose tricyclic antidepressants. I say low-dose because in Europe, where much of the St. John's wort research originated, they use lower doses of tricyclic antidepressants for depression than we do in the United States. And the more recent comparisons against the SSRIs suggest also that St. John's wort is probably as effective in the samples studied. Other investigations and sub-investigations have suggested that St. John's wort is beneficial in atypical depression, which is a type of depression characterized by increased appetite, weight gain, severe loss of energy, and mood reactivity, among other features. Also in premenstrual syndrome or PMDD, also St. John's wort seems to have benefits in that area. Our group, in collaboration with Mark Rappaport, who was then at UCLA, did a study in people with minor depression, which is a milder form of major depression. We didn't find any particular benefit from St. John's wort compared to placebo. Other investigations have looked at St. John's wort against conditions like attention deficit disorder, anxiety disorders, and obsessive compulsive disorders. And again, most of the studies don't suggest a significant benefit. Some recent research has suggested St. John's wort may have some benefits in Alzheimer's disease, but we need more work to clarify that question. One of the major concerns about using St. John's wort is that it does interact with several different medications. I've listed them here on the left of the slides. St. John's wort induces the activity of the enzyme cytochrome P3A4, which is very important in the metabolism of various different medications. Consequently, by inducing its activity, it accelerates the breakdown of the medications listed here, and thus reduces their therapeutic activity. As you can see, there could be some serious consequences of this. For example, in HIV patients who are taking indinavir, this could result in the development of resistant viral strains. And patients, for example, who are receiving transplant and are getting, say, cyclosporin to suppress the immune system, there could be cases of rejection of the transplant. And all of these things have been documented, and this makes it clear that we have to use these natural products with the same caution that we would any other medication. How does St. John's wort work? The key ingredients that are thought to be psychotropically active include hypericin, hyperforin, and adhyperforin. They interact with cytokine production in the hypothalamic pituitary adrenal axis, and it's thought that that's how they might induce the antidepressant effects. St. John's wort is generally considered safe, and most of the side effects tend to be mild, including dry mouth, dizziness, and constipation, kinds of things we see with antidepressants in general. There are some more serious side effects associated with St. John's wort, including phototoxicity or extreme sensitivity to sunlight and easy sunburning. Individuals with bipolar disorder have been shown to cycle into mania if they take St. John's wort, so we always advise caution with bipolar individuals. And interactions, as I mentioned. Another important interaction is that if you combine St. John's wort with serotonin reuptake inhibitors, there have been many cases of serotonin syndrome developing, which is a potentially fatal condition. And for this reason, we do not advise that individuals taking SSRIs combine them with St. John's wort. A common question about many of these natural and herbal products is, are they safe for women who are pregnant or who are breastfeeding? Though we don't have a lot of data, unfortunately. We do know that there have been some cases of colic, drowsiness, and lethargy in breastfed infants of mothers who are taking St. John's wort. And some animal studies have suggested lower birth weights may occur when the mother is exposed to St. John's wort. One human study of women who were taking St. John's wort did not find any fetal malformations as a result. So in general, we don't recommend use of St. John's wort in pregnancy just yet because we really don't have enough safety information. To conclude, St. John's wort overall is probably best for the individual with mild to moderate depression. They seem to be the ones who respond best to it as opposed to those people with more severe forms of depression. Next, I'll talk about S-Adenosylmethionine or SAMe, which is a compound that all living beings manufacture. And its main function in the living organism is as a donor of methyl groups. As you see in the slide, you see the green arrow pointing at that particular CH3 group. That's the group that it donates in various reactions that are important physiologically. In particular, the synthesis of different neurotransmitters. As you see in the diagram below, the SAMe seems to be one of the common pathways of folic acid and B12 metabolism. And it's very important in the final synthesis of dopamine, serotonin, and acetylcholine. And indirectly, it may be also involved in the synthesis of norepinephrine. One of the interesting areas of research as far as the impact of genetics in depression is the role of methylene tetrahydrofolate reductase polymorphisms, which is a very important enzyme in folate metabolism. About 10 to 12% of the population has an abnormal form of the MTHFR that can affect folate metabolism. So these individuals are thought to be particularly vulnerable to depression, and treatments like SAMe may potentially bypass the MTHFR anomaly. SAMe, like St. John's Wort, is also quite well studied. There's more than 45 published randomized trials on SAMe for depression, and these have administered SAMe in different forms, orally, intramuscularly, and intravenously. By and large, the studies suggest that SAMe is more effective than placebo and about equivalent to tricyclic antidepressants. Doses of SAMe used in the different studies are quite broad, from as low as 200 milligrams a day to as much as 1,600 milligrams a day in most studies. More recently, we carried out a comparison of SAMe monotherapy against escitalopram, an SSRI, and against placebo. In this study, we randomized 189 patients and treated them for 12 weeks. In this particular study, we allowed the SAMe dose to go up to 3,200 milligrams a day in people who didn't respond during the first 6 weeks. What we found here is that we ended up having a high placebo response rate. So all the 3 treatment arms, SAMe, escitalopram, and placebo, had a drop of about 5 or 6 points in the Hamilton D scale. So the overall results were what we call a failed trial, in the sense that the placebo response rate was too high to really allow us to draw firm conclusions about the comparison between SAMe and escitalopram. Our colleague Jerome Saris, who spent some time with our group and continues to collaborate with us, recently published a sub-investigation in which we examined the results by gender. And his analysis suggested that there may be an advantage for men with SAMe. So it's interesting, having heard Yutaka's work about omega-3s potentially favoring women over men. So this seems to suggest that there may be gender-related effects in the use of these products. One of the nice things about SAMe is that it doesn't have significant drug interactions, so it's often used as an augmenting agent in individuals who have not responded satisfactorily to standard antidepressants. So it can be combined with tricyclic antidepressants, SSRIs, and SNRIs, such as Cymbalta or venlafaxine. And some studies have even suggested that in combination it can accelerate the effect of tricyclic antidepressants, so that people begin to respond in 2 to 3 weeks as opposed to the usual 6 to 8 weeks. Our colleague Jonathan Alpert in our depression program at Mass General carried out a study with 30 individuals who had been taking SSRIs and either were partial or non-responders. And for 6 weeks they were given an open treatment with SAMe between 800 and 1,600 milligrams a day. The results were very encouraging. The response rate was about 50%, meaning a more than 50% improvement on the Hamilton D depression scale. The remission rate, essentially a complete cure, as it were, was in the range of about 43%. So this was encouraging, particularly considering that this was a treatment-resistant population. Dr. George Papakostas from our group followed up on this work, and in 2010 he published a study with 73 individuals on serotonin and norepinephrine non-responders. And these individuals were also treated for 6 weeks. This was in a double-blind randomized study, either 800 milligrams twice daily of SAMe or placebo. And the results of the study found a significant advantage for SAMe. Response rates were about 36% compared to 17% for placebo. Remission rates were also more than twice what we found for placebo. So this was a very encouraging study. And a sub-analysis of this work by our colleague Christina Dording suggested that SAMe may actually also have a benefit in men sexual dysfunction. We looked at the sexual function questions from our depression questionnaires. So again, this suggests another potential niche for SAMe. So as far as dosing, as you've seen in the literature, doses may be as low, at least for oral, will be as low as 400 milligrams or up to 3,200 based on our study. My general recommendation is for clinicians to not be shy about increasing the dose if necessary, because it is very well tolerated. That said, there are some side effects such as insomnia, loss of appetite, constipation, nausea, and many other things that are pretty minor. Individuals with bipolar depression who take SAMe have often been shown to develop mania or hypomania, so we do beware in this population. One study found that pregnant women who had intrahepatic cholestasis benefited from the addition of SAMe to their overall treatment regimen. However, we don't have a lot of safety data, so we do advise caution in pregnant women. Finally, it's important to remember that SAMe is very expensive compared to some of the other natural products on the market, at least in the United States. So obviously, because as I mentioned earlier, many patients have to pay for these treatments out of pocket, they have to be aware of the cost factor, especially if they're among those that require higher doses. Okay, I'll say a little bit about the omega-3 fatty acids, which you've heard about in practically every talk today. We've seen what the two main ones, DHA and EPA, look like. These are the ones that are of primary interest in psychiatry. This mechanism of action may involve many things, including neuronal membrane stabilization as well as anti-inflammatory effects, which you've heard about. With regard to treatment of depression, omega-3s are quite well studied. More than 30 randomized clinical trials have been published. Most of them either use EPA monotherapy or a combination of EPA and DHA, and the most common doses are often in the range of 1 to 2 grams a day, which are what's recommended. As far as DHA as an antidepressant, when thinking about it in terms of monotherapy, the results have been mixed. There was a study by Lauren Marangel in which she found that 2 grams a day of DHA was not effective for depression. Our group carried out a dose-finding study in which we found that actually 1 gram a day was more effective than 2 grams or than 4 grams a day. So it's possible that in Marangel's study they may have overdosed, so to speak, the subjects. Then again, there's the study that came out from Joe Hibboln's group, a study by Lewis et al., in which they found that DHA seems to have a protective effect against suicide in soldiers. And Joe tells me that they've been following up on this work recently, so we're looking forward to hearing more about that. As far as postpartum depression, Marlene Freeman, our colleague now at Mass General for several years now, has done a lot of work in this area, as has Lauren Marangel. And their studies have been somewhat limited by small samples, and we still don't have clear recommendations for postpartum depression. Then there's the issue of bipolar disorder. Andy Stoll published the first high-profile clinical trial of the omega-3s for bipolar illness in 1999. And Keck attempted to replicate these studies in 2006. By and large, the findings in bipolar illness suggest that omega-3s may be best for the depressed phase of the illness rather than for the manic phase. And this was based in part on meta-analysis by our colleague Jerome. Other studies, we don't know a lot about how effective they are in children. There have been some studies looking, for example, at flaxseed oil in pediatric bipolar illness, and this suggests some efficacy there. Other investigations have looked at borderline personality disorder and schizophrenia with less clear results. So there are many potential applications for the omega-3s. I'll talk about some of the most recent work that we've done. We were interested in the question of, is EPA more effective than DHA for depression? So we carried out a 3-arm randomized controlled study with 196 patients with MDD, major depressive disorder, and this was done in collaboration with with our colleagues at Emory University, also Dr. Mark Rappaport, who's the director of the program there. So these individuals received 1,000 milligrams of EPA or DHA or placebo and were treated for 8 weeks. As with our earlier SAME study, we found that all these patients improved with regard to the Hamilton Depression Scale, the QIDS scale, and the CGIS, but neither active treatment separated from placebo. The response rates were about 40 to 50% for each arm, and remission about 30%, again the same between groups. So this was initially disappointing. However, as part of this investigation, we were interested in measuring certain inflammatory biomarkers, in particular a C-reactive protein, interleukin-6, interleukin-1 receptor antagonist, leptin, and adiponectin. And this gave us the opportunity to find out if do baseline levels of these markers impact on response. And in fact, in a study we just published this past year, we found that the individuals in the study who had no elevated biomarkers at baseline tended to have a more modest response to EPA than to placebo. On the other hand, those who had 4 or 5 elevated biomarkers, this produced an effect size of 1.11 in favor of EPA over placebo, and this in clinical terms translated to a drop in 11 points on the Hamilton D scale compared to 5 points. So this was quite a robust effect. We also found that individuals who had more than one marker elevated tended to be overweight and had elevated CRP, leptin, IL-6, IL-1RA, and decreased adiponectin, which is anti-inflammatory. So that makes sense. So EPA, in conclusion, would appear to benefit those individuals who have elevated inflammatory biomarkers at baseline. And I'm happy to report that our group has just been given a new grant from the National Center for Complementary and Integrative Health, formerly known as the NCAM, to do a study looking at obese individuals with depression and elevated markers at baseline. And this will perhaps give us a chance to characterize more closely what particular individuals with depression the omega-3 fatty acids may be good for. So we're very excited about this work. I'm running out of time. So I've got a couple minutes. Yeah. All right. Let me just I'll summarize the omega-3 work and then maybe zip through a few more things. So in general, in people with depression, doses of an EPA and DHA combination at around 1 to 2 grams a day, preferably with more than 60% EPA based on Sublet's meta-analysis, would be desirable. There's a study by Mozaffari and colleagues suggesting that there might be an advantage for EPA, as well as the findings from our own study. The bipolar disorder study have used higher doses, sometimes in the range of 6 to 10 grams a day. So dosing is a consideration. As far as safety, stomach upset tends to be the main side effect reported, particularly with higher doses. And there is a concern about bleeding developing with anticoagulants. So we should be careful with that. Also, the issue of cycling in bipolar individuals, this has occurred. So we do advise caution in bipolar patients. As far as benefit to expectant mothers, well, I mean, we've heard all about the importance of the omega-3s, particularly DHA, in the developing brain. So ultimately, I think, and you're probably going to hear about this from Joe tomorrow, they'll probably be shown to be safe and desirable for women, but I think we still don't have a sense of what is the safest upper limit of dosing for pregnant women. So I think Joe will probably enlighten us on that tomorrow. Okay, so I'm out of time. Some of the other treatments that are particularly popular are ginkgo biloba, which is also well studied and suggests benefits as far as individuals with cognitive decline from dementia. And it's been compared against the cholinesterase inhibitors. By and large, the cholinesterase inhibitors tend to have an advantage in efficacy, but ginkgo has an advantage in tolerability. And the two can be combined safely, and there seems to be a synergistic effect between them. So combining them might be a good way to go for dementia. One thing to remember is that a long-term treatment is necessary, and ideally patients should be treated for at least a year before we come to any conclusions about efficacy. Kava, an herbal remedy used to treat anxiety, not as well studied as some of the other treatments I touched on. There's been a lot of concern about liver toxicity occurring with different forms, with different preparations of kava. It's thought to be due perhaps to some hepatotoxic molds that have developed in some of these preparations. We generally avoid using it if you have a liver disease or alcohol use or taking medications that are potentially toxic to the liver. So if you have patients who are taking it, best to monitor their liver enzymes regularly. Valerian, also very, very popular. It helps individuals to sleep better at night. The meta-analyses that have been published on the studies have not been entirely convincing. One problem with studying valerian is that it has a very powerful and distinctive smell. And this makes it hard to use in controlled studies. Melatonin, also very popular for resetting one's circadian rhythm when traveling. Again, fairly well studied, including in children and the elderly. Mostly safe to use. Do beware of using doses that are too high because they may cause daytime sleepiness or confusion. So to conclude, the kinds of individuals that I steer to natural products are those who are mildly ill, have a strong interest in complementary medicine, and don't mind the out-of-pocket costs. There's also those who have tried other things and haven't responded or had too many side effects. And always be careful in individuals who are taking multiple medications because of some concerns about interactions that I mentioned. Thank you very much. Sorry for going over.